Pacritinib is a JAK2 IRAK1 inhibitor. It is an oral drug that can be given at 200 milligrams twice daily to afford patients spleen and symptom benefit. And what the PERSIST studies, which were the randomized phase 3 studies, demonstrated was that this drug is tolerable and effective, and particularly so in patients with low platelets. And that, I think, is an important message, that there's an unmet need of the cytopenic MF patient profile. These are patients typified by low platelets, often a low JAK2 allele burden, frequently primary myelofibrosis, that are not ideal candidates for Ruxolitinib as the label, or fedratinib as the label is for 50,000 or greater. So it leaves this unmet need where patients can benefit from an additional JAK inhibitor. And Pacritinib has really distinguished itself from the PAC in terms of its lack of or less myelosuppression than the other drugs in early phase studies and in the PERSIST program. So this was an analysis specifically looking at patients with low platelets, less than 50,000, that came from the PERSIST-2 and the PAC203 dose finding study, and comparing them to the BAT arm in the PERSIST-2 study. And in a nutshell, what it confirms is that you can deliver the intended dose, full dose of 200 milligrams twice daily of Pacritinib, and maintain that dose with superior efficacy in terms of spleen and symptom benefit, but importantly, maintaining safety. So although there are expected higher grade 3-4 treatment emergent adverse events with Pacritinib compared to supportive care, the frequency of cardiac events, for example, which was an initial concern with the drug, was not elevated compared to BAT with these drugs. And what I think the PAC203 study, or the PAC203 dose finding study, confirmed for us is that if one is careful about optimizing patients in terms of coagulopathy and those patients that may have an inherent bleeding risk, you can minimize your bleeding risk, grade 3-4 bleeding risk with Pacritinib. So although there may be a slight increase over BAT, there are ways to optimize or minimize that risk going forward, and the benefit typically outweighs the risk. So it was an analysis that basically confirmed the safety profile and tolerability, particularly in this vulnerable patient population that's in need of JAK inhibitor therapy. In a similar vein, in the PERSIST-2 study, in which there were patients who some were Rux exposed, some were Rux naive, were randomized to Pacritinib at 200 milligrams twice daily, 400 milligrams once daily, and BAT, in which nearly half the patients received Ruxolitinib. And these were patients who had a platelet count of less than 100,000, so the cytopenic MF profile. What we showed there was that if you specifically looked at the Pacritinib 200 milligram twice daily and the Rux treated patients in BAT, again, you maintain dose intensity with Pacritinib, where that was often lost with Ruxolitinib due to cytopenias, and there was superiority in terms of both spleen and symptom improvement when looking at this extreme thrombocytopenia, less than 50,000 patient cohort with Pacritinib compared to best available therapy.